Now the appendicular skeleton, we're going to do the arms and legs. You should know all the bone markings. You should know what's proximal and distal, right? And then some of them I'll ask you to tell me right or left. Sometimes it's not fair, to be able to see right or left on certain models or skeletal parts. So we'll look at the upper and lower limbs. The upper arm, you're going to see, consists of the brachial area is the humerus, and the antebrachial area, which is the forearm, is the radius and the ulna. The lower limbs, the upper thigh, proximal, is the femur, and the lower limb is the tibia and the fibula. And we'll do the wrists, the ankles, the hands, the feet, and the fingers and toes. And that's a lot of it. That's a lot of stuff. Okay, I'm not going to ask you about how many bones there are because you could figure that out as you're doing it. Something about weight bearing. I think in lecture you might have heard of something called Wolff's Law, where the lower limb bears most of the weight, especially the tibia. The fibula doesn't bear a lot of weight. Your hips and femur bear a lot of weight, especially in the standing position. The upper limb is not made for bearing weight. So more prone to injury when you do bear weight on your upper limbs, your shoulder joint, which you learned in lecture. So we'll go through the pectoral girdle, where the arms articulate with the thoracic cavity, the scapula, and the clavicle, simple, one bone, and very non-weight bearing. Considered a flat bone, actually. So the two things you need to know about the clavicle are the ends. And sternal end is the medial articulation of the right and left clavicle. The acromial end is the lateral articulation. And that's important. So you should know what the acromion process is. I might have showed you that when we did directional terms, just to give you an idea. And it forms a joint. Usually the joint is named after the articulations, like the acromioclavicular joint is the AC joint, or the glenohumeral joint between the head of the humerus and the glenoid cavity, which we'll talk about. You should have heard these terms in articulations. Costal tuberosity and conoid tubercle, probably not on your list, but I need you to know the ends. And again, this is not completely fair because you can't pick up the bone. So I'm going to have to provide you some good videos of these bones. So the clavicle has two ends. And look, this is your point of view. Like, I think every picture in this PowerPoint gives you, like, this is the right clavicle. Remember, he owns the anatomy or she owns the anatomy. So this is their right, this is their left, and this is the anterior view. So now we're getting a superior view as if we're looking at the top of the clavicle, which makes things a little more complicated. So this is the right clavicle. So the sternum is here. The sternum is like kind of a little notch where they have the manubrium, remember the manubrium on top, and then the body of the sternum, and then the xiphoid process. So this forms a joint with the manubrium. The sternal end is very sharp, and the acromial end, out lateral, is more blunt. So, and this is a superior view, and if you turn it over, still the right clavicle, you're not going to have to tell me right or left clavicle, never. So the acromial end has a little thicker part to it, and has the conoid tubercle, which you could see. Probably won't ask you that, but you should know acromial end and sternal end. And I'll send you some videos to help you with that. See, the sternal end is kind of sharper, flatter there. Okay. If you have a question, please speak out because I can't go to the chat. Thank you. All right. And it shows anterior and posterior. You can see how the anteriorly, the clavicle kind of bows forward. And that's about it for the clavicle. Again, I have to show you models, and we'll see what they have on MH Connect. It's pretty simple. It's pretty simple. I actually saw it. Okay, so here's the tough bone. This is your first hard bone to name the marking. So I got to go a little bit slow here. So the scapula is the shoulder blade, and there's two of those, of course, right and left. And you have to know right and left, and I'll show you how to do that. So one of my key structures is called the spine of scapula, which is always posterior. Okay, which is really important. And off the spine of the scapula, laterally and posterior lateral, is the acromion process. It's big. And anterior of the clavicle has another process called the coracoid process. Let me just pause this for a second. I'm sorry. I just paused this recording. So of course I'm gonna have to show you pictures of all this, and you're gonna have to go through those videos because this is really difficult to look at in pictures. So you should know what's superior, what's medial, and lateral border. And let's see, angles. I'm really more interested in the inferior angle, and the fossas will go through. And later on, you're going to see that these fossas of the scapula are origins for your rotator cuff muscles, like subscapularis, which remembers anterior scapula. Supraspinous is superior, but you can see it more from the posterior. It's right above the spine. That's what supraspinous means, above. Sub is usually below the scapula, but that's really kind of doesn't make that much sense, but you'll see it. Infra is only posterior, and it's inferior, because infra means inferior. Remember the foramen on the skull, the infraorbital foramen and the supraorbital foramen above the orbits, below the orbits. The superior orbital fissure, which is in the orbit. Fissure is like more of a slit than a hole, right, Rajan? And then this inferior orbital fissure. And these are all passageways for nerves and blood vessels. So these are just fossas. These are just kind of flat areas that are part of the bone where muscle is going to sit. In fact, these are the sits muscles, like sits muscles, S-A-S-I-T-S, or the supraspinatus muscle, which is in the supraspinatus fossa, the infraspinatus muscle, which is in the infraspinatus fossa, and the subscapularis, which is anterior scapula. And then you're going to learn a muscle called the teres minor. So these are all your rotator cuff muscles. So supraspinatus, infraspinatus, teres minor, and subscapularis. So they all have origins on the scapula. Teres minor has an origin on the lateral border of the scapula. So this is why we have to learn these bone markings, because you have to know the origins and insertions of muscles. The origin is the fixed bone. The insertion is the bone that's going to be moving, which you'll learn. And the action is the actual movement that you learned in joints, like flexion, extension, rotation, internal and external rotation, flexion, lateral, abduction, adduction, supination, pronation. So here's the scapula, and this is how I tell the scapula. This is your posterior view to your right. And how I tell that is that the spine is only posterior. The spine of scapula is this long, thick ridge. So that's the spine of scapula. And that I'm going to ask you, because you have to know that's posterior. The next thing is the lateral, and this is posterior, the lateral cavity, which is called the glenoid cavity. Now for this one, you could say fossa too, I don't care. But don't say foramen. So that's a cavity, because the humerus, the head of humerus, is going to articulate with that to form the glenohumeral joint. So the humerus is lateral, right? Here's the humerus here. See it? And this is your point of view, posterior scapula. And this thick posterior lateral, and you can feel this on your own shoulder. If I put an X there, and I'm going to ask you this. This is the acromion process of the right scapula in this case. How do I know it's right? Because the spine is posterior, the glenoid cavity is lateral, because that's where the humerus is, lateral. So I know this is the right scapula based on that posterior view. You could figure that out if you look at the articulated skeleton. Now here's the fossas. Now above the spine, right, supraspinous means above the spine of scapula, and that's where the supraspinatus muscle will have its origin. Now below the scapula, below the spine, you have the infraspinous fossa. Infra is below, and that's where the infraspinatus muscle is going to have its origin. So based on knowing that the humerus is lateral, you know that this is the lateral border, and this is the medial border. And the bottom of the scapula forms an angle called the inferior angle. There's a superior angle, right? And then there's the superior border, and then there's the suprascapular notch. So you can see that better from the anterior view over here. And a notch is just a space where you know that blood vessels, tendons are going to traverse through that space. So that's a notch. Okay, so know the medial border, know the lateral border, know what's lateral, what's medial from the posterior view. Now the anterior view is a little simpler. Now remember, this is the right scapula. So you can see the glenoid cavity is always lateral. It's always lateral. So the humerus is going to articulate lateral. This is the anterior view of this articulated skeleton. Now the acromion is the most lateral, so you can see that out here. Now anterior scapula has the coracoid process. You have to know the coracoid process is anterior process of the scapula, and it's lateral too. So here you could see a piece of it on the posterior view, but you see it much clearer here. Again, you're at a disadvantage because you're looking at a two-dimensional picture, and there's an overlap. So you have to look at different views of it, and MH Connect will help you with that, and my videos hopefully will help. So again, this is all medial here, both sides. This is both the right scapula. You have to look at the point of view. This is anterior view. This is posterior view. So this is where your subscapular fossa is. I'm going to ask you that. I'm going to put a big X here, and you're going to see there's no spine, and you're going to say that's anterior. So I could see the coracoid process is anterior. I can see this is lateral because here's the glenoid cavity, and this is the lateral border, and this is the medial border. Not easy. Not easy. To know right and left, at least. So practice that. So upper limb, we're going to talk about the brachium, which is the arm, and that's going to be the humerus and all the parts of the humerus. And there's a lot. Nothing funny about that humerus. Antebrachium is the forearm, and you're going to have the radius. I'll tell you about the radius. The radius, in the anatomical position, you have to know the anatomical position and what that means. In the anatomical position, you're looking at anterior skeleton, thumbs pointing outward. So the thumb is called the pollex. The radius articulates on thumb side. So the radius in the anatomical position is always lateral. And then the medial bone is called the ulna, and it's bigger. And that's medial in the anatomical position. And the radius radiates around the ulna when you supinate and pronate your hand. So it moves. That's why they call it radius. So it's thumb side, I'll say that, pollex side. It doesn't articulate because the radius is going to articulate with the carpals, the wrist. But it's on pollex side. And you're not going to say thumb on an exam. You're going to say pollex, or first digit of the upper limb. So I'll just say thumb or first digit The thumb is always the first digit, and you count across to 5. The hand is basically your metacarpals. And there's 8 of them. Sorry, carpals. So there's 5 metacarpals, 8 carpals. Okay. So the humerus is your upper arm bone. The radius and ulna. Radius is always lateral in the anatomical position. There's 8 carpal bones, and that's your wrist. So your radius is going to articulate with one of the carpal bones. And then you have 5 metacarpal bones, and that's your hand. And then you have your phalanges, which are your fingers. And you're going to see that digit 1, sometimes they put it in Roman numerals like this. I think your book uses Roman numerals for 1. So digit 1 is the pollex, the thumb. And that only has a distal and proximal phalange, just 2. Has nothing to do with the length. Sometimes they call it phalanx, which you'll see for singular. So the rest of them, so 1 through 4, or 1 through 4, the way that your book writes it, they have 3 phalanges. And it's going to be distal, middle, and proximal. Okay? That's why this doesn't add up to 16. Okay? So 1 through 4. So, I'm sorry, 2 through 4, not 1 through 4. 2 through 5. Wake up, man. Wake up. Wake up. So it's 1 through 5, 2 through 5. So the second digit is your index finger. Third digit is middle finger. Fourth digit is your ring finger. And fifth digit is your pinky, also known as the digiti minimi. So digit 1 is 2 phalanges. 2 through 5 is 3 phalanges. Sorry about that. Okay, so the humerus, the upper bone, and make sure you can tell the difference between the humerus and the femur as you're going through your lab, because they look very similar. And unless you see them both together, sometimes at first glance, you get those confused, believe it or not, even though the femur, of course, is longer. But again, you're not looking at the bones in a lab, you're looking at pictures. So there has to be a point of view. Sometimes we kind of like zoom in on the bone. It makes it look even more confusing. So the humerus is a long bone, of course. They're all long bones except for the carpals in the upper limb. Everything's a long bone, except the carpals are the irregular, short bones. So we could ask you that too. So know what proximal humerus is. That's closer to the glenoid cavity, right? Forms the glenohumeral joint. And the glenohumeral joint is when you dislocate your shoulder, that's the joint that you're dislocating the humerus out of. So the humerus moves out of position. In the glenohumeral joint, when you hear the term dislocation of a shoulder, like when you have a patient or you're taking an x-ray of somebody, you could see a dislocation on an x-ray because the humeral head, which is proximal, has dislocated out of the glenoid cavity. It's a ball and socket joint. And of course, it's a synovial joint, which you learned in lecture. Now here's a couple of the markings. In the humerus, you're going to hear a term called tubercle. And there's a greater tubercle and a lesser tubercle. And the greater is more lateral. And the lesser tubercle is smaller, and it's more medial towards the head of the humerus. So the head, you should know, is more proximal or medial. Of course it is, because it's articulating with the scapula, which is medial to the humerus. So get those directional terms down. And there's a sulcus. Here's another word, Rajan, sulcus. is like a groove, really, with some thickness to it. So in between the tubercles, inter always means between. Inter means between. So there's a sulcus between the two, like a little valley. I like to use the term valley. And that sulcus is going to house certain things like tendons from the brachialis muscle and the biceps brachii, which you'll learn next week. So there's two necks. I don't make a big deal out of this. Anatomical neck versus surgical neck. There are two different spots. Anatomical neck has to do with where the growth plates were, the epiphyseal plate. So that separates the epiphysis, proximal epiphysis, from the diaphysis. The surgical neck, they call it that because this is a common site for a fracture. And I think there's a good picture coming up in this PowerPoint. Here's another word, tuberosity, which is kind of what happens when a muscle, like the deltoid muscle, is attached to a bone. And over time, evolution will actually pull some of that bone away from the surface, so it forms like a little bump. And it's a site of attachment, muscle attachment. So there's a couple of tuberosities. I think there's only 2 or 3 tuberosities you need to know. But this is on the humerus because the deltoid is a big muscle over the humerus, the shoulder muscle, for abduction, adduction, and flexion extension of the shoulder, the deltoid muscle. Most muscles are named after their shape. It's a deltoid shape. The radial groove near the deltoid tuberosity, pretty easy to see. I probably won't ask that. You have enough to worry about with the tubercles and the grooves and we're just still at the proximal humerus, shoulder joint area. Now this is more distal, the distal humerus now, towards the elbow. So know your directional terms. Yeah, we're still in the humerus. So you have to know what's medial and what's lateral. The medial epicondyle is, I think it's longer than the lateral. And you'll see that. It's kind of visual. So epi means atop, and condyle is another like bulbous part of a bone. But there's no condyle we're going to name in the humerus. We're going to name condyles in the femur and the tibia. But in the humerus, I'll never ask you for condyle, but I will ask you for the epicondyle, especially the medial epicondyle, because it's a projection, and it's a longer projection in the medial end. And again, these are muscle attachments and ligament attachments. Remember, a tendon attaches muscle to bone, and a ligament attaches bone to bone. So they have muscle, ligament, and tendon attachments. Of course, if it's a muscle attachment, you need a tendon. Palpated means to feel. So you could feel that if you turn your arm over on your desk or table, you could feel those epicondyles in your elbow, lateral and medial, not in the back, right? So you have nerves that run through there. Of course, you can get some weird feeling, like a funny bone. If you ever banged part of your elbow, you feel like a buzzing feeling. And usually that's a nerve, like the ulnar nerve. But the epicondyle, I won't ask anything about the funny bone. Wait till we get to neuro for that. Now here's the hard part. Now this is distal, and you have 2 major parts, and they're hard to see. The capitulum looks like a marble, and what you should know about the capitulum, you only see it anterior, and it's lateral. If it's anterior and lateral, it articulates with the radius. Because in the anatomical position, the radius is the lateral bone, thumb side in the anatomical position. So the capitulum is going to articulate with the radius, laterally. Lateral. And it looks like a little marble. Trochlea looks like a little bow tie, and that's medial, and it's bigger. And that's going to articulate with the ulna, because the ulna is medial in the anatomical position. It's hard to tell right and left in those, though. I won't ask you the right and left ulna or radius for sure. But we're not talking about ulnar and radius. We're talking about the humerus, which I will ask you right and left. A couple other parts, these are really important. Radial fossa, not so important. I'll show you where that is, and that's just the, on the humerus, you have a little groove. They don't call it a groove, they call it a fossa, where the radius is articulating with the humerus. But these two are important. Coronoid process is anterior. Fossa, sorry. The fossa of the humerus. We're still talking about the humerus. So the fossa is going to house the coronoid process of ulna. So that's, of course, again, is anterior ulna. And it's a little smaller than the olecranon fossa. It's smaller, and I'll show you that. So the olecranon fossa of humerus is posterior. And that accommodates the olecranon process. You can just, it's like the acromion, and you're gonna have to remember this term, because I'm gonna ask you about the olecranon. The olecranon is the posterior part of the proximal ulna. So olecranon is really important, olecranon process, but you could just call it olecranon later, of ulna. And that's gonna go into the posterior fossa of the humerus, which is called the olecranon fossa. A lot of stuff. So here is the humerus, and look at the pictures up here. This is the anterior view, and that's the right humerus. This is the posterior view, and still the right humerus. So let's look at anterior first. And this is where it gets confusing with the femur. Medial, you have the head, and the head is what's going to articulate with the glenoid cavity of the scapula on the right and left. So know the head. The greater tubercle of the humerus is always bigger and lateral. So you could feel that too. It's right below the acromion. Acromion process is back here. The lesser tubercle is anterior, and it's a little smaller. And there's a sulcus between those two, and that's what inter means, intertubercular sulcus. And here's the anatomical neck up here. That's between the epiphysis, proximal epiphysis, and diaphysis, is the anatomical neck. Surgical neck, which is much more commonly fractured when you fall onto this, is below the metaphysis, more towards the diaphysis. So metaphysis is a space between the epiphysis and the diaphysis. So know the tubercles. These are really important, and know this is the anterior view. Now mid-shaft or so, it's really upper mid, you have a little bump right here, and I'll put a little X on the exam, or it'll be highlighted. And you can see that is the attachment of the deltoid muscle, called the deltoid tuberosity. So all this is shaft, also known as diaphysis. Now the proximal humerus posterior now on this side. Again, the head is medial, articulating with the glenoid cavity of the scapula. Now you can still see the greater tubercle, but you can't see the lesser tubercle because that's anterior. The anatomical and surgical neck are in the same place. You still get a good look at the deltoid tuberosity. And then you have the radial groove, is posterior only. And this is where the radial nerve is going to traverse. Radial nerve, which is part of neuro, and I'm not going to ask you about that. So know all the parts of the proximal humerus. Distal humerus now we're down towards the elbow. And this is an inset of the distal humerus right here in the model. So let's look at the anterior first, and you have to stay with me here. This is where it gets difficult. The first thing I notice when I look at an anterior humerus, right humerus in this case, I see the medial epicondyle, and I would put an X right there. Medial, right? And you can see it on the posterior too. So I know that this is medial. Or every time, even if I just put a picture of the humerus, which I will, and you have to know where that is. Then I look for the only bone I could see on the anterior, and it's that little marble-looking bone called the capitulum. And that's going to articulate with the radius because that's lateral. So remember, this is lateral side. This is lateral over here. Look at your bone markings. The head has to be medial. So medial is here. Remember, this is just posterior and anterior view. So right next to the capitulum, you have what's called the trochlea, and that's this bow tie looking bone here. And you can see that from posterior and anterior. And that's called the trochlea. So the ulna is going to articulate with the trochlea. Very important. Then you have anterior, you have this fossa called the coronoid fossa, which is a little smaller and shallower. Posterior, with your elbow, like if you slam your elbow down on the desk, you're hitting the olecranon of the ulna. So this is the posterior fossa. Remember, this is a posterior view. So the olecranon fossa is deeper and wider, and it's posterior, always posterior. Olecranon is posterior, olecranon fossa. And you'll see here's the ulna, the proximal ulna. And the ulna, the proximal portion of the ulna is like a wrench that kind of grabs onto the trochlea. And this is the radius here. This happens to be anterior. You can see the capitulum here. Again, it's not easy with the picture. Nothing looks like this. This is the head of radius. Nothing looks like that. So that's the head of radius, which you'll see in the next couple of slides. So again, I'm going to have to put some videos, and you can see the different bones before the practical. So at least you'll be able to look at the bones in motion, moving around, turning around, because you're just looking at static pictures. It's not easy. So those are really important. Now the radius. Radius is fairly simple. It has that head, looks like a nail head, which is the proximal radius. So now we're talking about the radius. And it has a tuberosity, which you'll see, radial tuberosity, which I probably won't ask you. That's the site of attachment for the biceps brachii. But you have to know the head, and you have to know it's proximal. And you have to know that the radius is lateral, thumb side in the anatomical position. Just keep remembering that. That's a big help. So more radius, you see the shaft, that's the diaphysis. And this is the other part you need to know, is the styloid process. Styloid process is distal. So that's going to articulate with the carpals, like the scaphoid, which you'll see. So in the wrist. So the distal end of the radius is now in the wrist. And that, you could feel this too. If you put your arm in anatomical position, you could feel the styloid process of radius, and it's lateral. And there's a notch, ulnar notch, to where the ulna articulates with the radius. So here's the ulna. And you pretty much have to know all these parts. The trochlear notch is just a space, right? It's just a space. And you'll see that because the trochlear notch is what's going to be in contact with the trochlea of the humerus. So it's interlocking, kind of like a wrench. So the ulna is the wrench. The trochlea is the nut or bolt that you're actually turning through that hinge joint. Of course, it doesn't move. Olecranon is the posterior part of your ulna, proximal ulna. And that's that bump. Like again, if you slam down your elbow on the desk, you'd be hitting the olecranon process. But you can just say olecranon. So that's posterior. The coronoid process, you should have to know, is anterior. Remember the fossa that's on the humerus, the coronoid fossa, anterior on the humerus. And it also has a head and a styloid process down towards the wrist. So this is medial though, medial. So the opposite side of the radius. And you remember the interosseous membrane between the radius and ulna, forming that joint, that syndesmosis joint. Right? I'm not going to ask you about joints. But you have to know the bones, so you have to know what the joints are made of, basically. But you did synovial joints in lecture. You did symphysis and all the rest of the joints. So we're not going to do too much joint and connective tissue. We've been through this already. Okay? But you have to know these bone markings that I'm telling you here. So this is two different views of the ulna and the radius. So anterior view, remember the radius, and this is the right side. Look at the point of view. This is your anterior, right, and this is your posterior. This is the right. So the skeleton's turning around. Still in anatomical position. Okay? So radius is always lateral. There's the head of the radius. There's your radial tuberosity, which is seen more from the anterior. It's an attachment for the biceps brachii muscle, the insertion, where this is going to be the movable part, because the biceps brachii flexes your elbow, brings your radius closer to your shoulder. So the movable part is the radius. Here's your styloid process, which is lateral. So you're going to have carpals down here in your wrist. Lateral. Remember, radius is on thumb side, lateral. I know I keep saying that. That's really important. Now, if you look up here, this is just a space between the olecranon, which is posterior, and the coronoid process, which is anterior. So the notch is just the space that's going to fit into the trochlea of humerus to form that elbow joint. And then there's a tuberosity of ulna, which is anterior again. Of course, they have a neck. And the shaft is the diaphysis. And the ulna is medial. Remember, this is medial. And these are both the right bones. And here's the interosseous membrane. So the radius moves, the ulna does not. And there's a distal radial ulnar joint, which you remember. The ulna's head is distal. Ulnar head is distal. And here's the styloid process of the radius. And here's the styloid process of the ulna. Most likely, I would ask you the styloid process of the radius. But you still should know the styloid process of the ulna. It's right here. I kind of blocked it, sorry. It's so small compared to the styloid process of the radius. So again, you're at a disadvantage here because you can't pick this bone up and move it around 3 dimensions. So let's look at the posterior. Now you can clearly see the olecranon process. You can't see the coronoid because it's anterior. Here's the head of the radius, which is always lateral. Nothing looks like that. And here's the styloid process of the radius right here. Very difficult. So it looks like you don't have to know each one of the carpals. So these are the wrist bones. There's 8 of them on both sides. I don't know why there's 8. I have no idea why we need 8 carpal bones in our wrist. Makes no sense. Causes more problems like carpal tunnel syndrome, for one, which is a nerve impingement of the carpals on a nerve. So there's rows, 2 rows. Scaphoid, you're going to see, is the one that articulates with the lateral radius, of course, so it's more lateral. And then goes to the middle, lunate, triquetrum. Pisiform is a little round bone that's only seen on the anterior view. Then you have another row of trapezium, which is fairly big. Trapezoid, named about its shape, kind of trapezoid shape. Capitate, right, kind of in the middle. Hammer has a little hammer attachment to it. So those are your 8 carpal bones, which I don't think you have to know all of those. Okay, metacarpals are your hand, basically. Right, hand. So again, they go 1 through 4. There's 4 metacarpals, long bones, and I'll show you those. So that's your hand. Easy. It's easy. I just got to show you how to separate them. Then the phalanges, remember the thumb, which is digit number 1, or 1 Roman numeral, only has 2 phalanges, proximal and distal. Now 2 through 5 have 3. They have all 3, proximal, middle, and distal. And these are your fingers. So here's the hand. This is an anterior view of your right hand. Okay, now remember, this is anatomical position. The radius is lateral. The thumb is lateral. First digit, right? See how they're counted? 1, 2, 3, 4, 5 to the digit minimi, which is the pinky. So here's the ulna. Again, here's a good picture. Look at this. The styloid process of ulna is right there. Styloid process of radius right there. So when you see the thumb, you know this is going to be the radius. It's lateral. It's not easy. Pinky has 3 phalanges: distal, middle, and proximal. Thumb only has distal and middle phalanges. So your wrist is all these bones within this circle that I'm drawing here. Those are your wrist bones. Your fingers are these down here. These are your fingers. And your metacarpals is your hand. So if I point here, you're going to have to say third metacarpal of the right hand. Right? Now here's the phalanges, fingers, proximal 1, proximal 2, 3, proximal 4, proximal 5th phalange, proximal. And then here's your middle. Again, 2 through 5. And here's your distal. Every digit has a distal and a proximal. Only 2 through 4 have a middle. Middle here, sorry. Okay. So here's the bones of the carpals, and they have different names like scaphoid, lunate, triquetrum. Here's the pisiform, which you can only see from the anterior view. This whole bone here is your trapezium. There's a trapezoid, like this is all trapezium. Trapezoid, capitate, and this is all hamate. So again, you don't have to remember these. I would like you to know that the scaphoid articulates with the radius on the thumb side. So there's mnemonics you can learn, like the first letter, like scaphoid, lunate, triquetrum, trapezium, trapezoid, capitate, hamate. So one of the mnemonics I learned 40 years ago was some lovers try positions that they can't handle, to remember the anterior bones of the carpals. So the posterior view, you can't see the pisiform. And I have videos of that, 2 pictures, bone models that you could practice with. Okay. I'm just talking about flat fractures. This is one of the scaphoid carpal is on the thumb side, between the radius and the metacarpal and the trapezium, of course. So this is when you fall and you kind of, or even like you're driving a car and your wrist gets thrown back, you could break a scaphoid, right? And it doesn't really heal very well. So you have death of the cells. That's what necrosis means, death of cells, because avascular means lack of blood supply. So it's long-term healing. So I'm not really going to ask you that, but just picture where that bone is. And talking about the wrist, and you learn the wrist joints. Okay, I think we're going to take a 5-minute break just to stretch your legs. So now we're going to go through the pelvic girdle a little bit. I did this last time. I showed you male and female. I looked at the recording from last week. But I just want to review some of the big parts. Of course, one side is called ascoxa or asacoxa. Ascoxa is fine. So here's the part where I'm going to ask the acetabulum for sure. The ilium, what the difference between the ilium and the ischium and pubic bone. Remember 3 bones, ilium, ischium, and pubic bone, or pubis. Okay, so there's really nothing on that page that are important. You should know the auricular surface, which forms the articulation between the sacrum and the ilium, called the sacroiliac joint. I will ask you this: iliac crest, the superior border of the ilium. And I'll show you some pictures. It's so much easier with pictures. The ischial spine, you should know. Ischial tuberosity, too. That's the part that you sit on. This is a good recording, too, to help you. Obturator foramen, for sure. Pubic crest is a good one. But if you just said pubic bone there, you'd be fine. So here's an anterior view. And one os coxa is all three bones, you see? And they're connected anterior with the pubic symphysis. So I'm going to ask you the pubic symphysis on an exam. And then you should know the difference between the sacrum and the os coxa, of course. So rule that out, and the coccyx. And the os coxa is the three bones. So ilium, ischium, and pubis. Yes.
Question. So
Yeah.
practical, right? We just have to more like memorize all the bones names.
Yeah,
Do we
pretty much. Yeah. I
going?
mean, there are some written questions, but I'm going to keep that really simple. Like
Okay.
directional terms, like I keep talking about anterior, posterior, proximal, distal. So I'll make sure and that'll be really easy. Just go through that PowerPoint, and I did it on a recording last time.
Okay.
So yeah, it'll be mostly exactly what I'm doing. Like, I think MH Connects highlights things though. Like I'm putting, I used to put X's like I'm doing now. So acetabulum, of course, is really important. That's here. You can tell right or left with that. Obturator foramen, big hole, right, Rajan? And then you have, you can't really see the ischial tuberosity in this picture. And here's the iliac crest. So what I used to do is put like X's all across here, and the answer would be iliac crest of the right os coxa, and this is iliac crest of the left os coxa. And you have the anterior superior iliac spine and the anterior inferior iliac spine. Here's the anterior inferior iliac spine, and this would be the anterior superior iliac spine. And here's the ischial spine you can see from the anterior. Let's see if I get a side view. And this, I always ask the posterior greater sciatic notch. Now, notch is just the space. Remember the suprascapular notch? Again, acetabulum. Here's the ischial tuberosity. So you can see all this is posterior. Again, it's not that easy. It's kind of unfair almost having to look at pictures instead of looking at the bones at this point. So ischial tuberosity. The pubic tubercle is actually part of the pubic bone. So you see the pubic bone comes down to about here. And then this is all ischium. And here's the greater sciatic notch. The lesser sciatic notch, not so important. I probably don't ask that. But ischial spine, greater sciatic notch, ischial tuberosity, and posterior superior iliac spine, posterior inferior iliac spine. This is the gluteal line, because that's the connection, attachment for the gluteus muscles. Ala is just a general term for like a flaring area, like the ear, has an ala. So I won't ask you that. But acetabulum, definitely. Ischial tuberosity, obturator foramen, greater sciatic notch, really important. So that's a good little review there for you. This is the medial view. So the sacrum articulates here. So this is the auricular surface. Medial right. Os coxa. I'm not going to ask you right or left though on this. It's just too difficult, looking at pictures. I used to do that with bones. When you're looking at the bones, it's just too hard for you. Here again, obturator foramen. You can't see the acetabulum because this is the medial view, but you can catch a piece of the ischial tuberosity, the pubic tubercle, the surface where the pubic symphysis is. So if you said pubic symphysis, you'd be 100% correct right there. This is the arcuate line, which I only use as a directional guide. And iliac fossa, that's a good one too. Iliac fossa would be a nice term. If you said iliac bone, ilium, you'd be fine there. But this is important that you write out iliac crest for this. It's a really good bony landmark for you to know. So again, the superior and anterior iliac spines, posterior, superior and inferior iliac spines, and the greater sciatic notch, yes. Ischial spine, yes. Here's the lesser sciatic notch. Probably won't ask that. So everything that's starred on this page is good. You know, again, if it's, I'm not going to harp on it if it's not in your checklist, but I'm going to ask you acetabulum, I'm going to ask you obturatum, I'm going to ask you greater sciatic notch. I'm going to ask you iliac crest for sure, for sure. Can't ask everything because this is all the bones and all the muscles in one test, which makes it even more harder for you. All right, sex difference we went over last time, and now the lower limb. And this is where we'll finish, and we'll go over to APR, see what they offer us for help. Okay, so the femur, right, is the thigh bone. And know the difference between the femur and the humerus, right? And the leg is the tibia and fibula. Remember, the fibula is always lateral and it's thinner. And then the foot is basically the metatarsals. Now, tarsals now, we're away from the wrist, now we're in the ankle, or towards the ankle. Metatarsals. So again, anterior, you see, I'm going to mention this in the beginning, anterior is the patella. Anterior. So the patella is a sesamoid bone in shape, and it really doesn't articulate with anything. Even though it has articular surfaces, it's basically suspended in the quadriceps tendon, which attaches the quadriceps muscles to the patella. And below the patella is the patellar ligament. So the patellar ligament attaches the patella to the tibia. Tibia, remember, is always medial. There's one tibia on each side, right? Not just one tibia. Technically, there's two tibia. Tibiae. Fibula is lateral. And the tibia bears more weight and it's thicker, much thicker. And 7 tarsal bones. These are easier than the carpals. So this is your ankle. Your metatarsal bones, 1 through 5, are your foot. And your 14 phalanges are your toes. So the big toe is called the hallux. And that's the first digit, the hallux. And of course, that would be number 1. And the hallux in the foot is medial. Medial, left and right. And it only has 2 phalanges. Proximal and distal. So the hallux, remember, is the big toe. Okay, so digits 2 through 5 have 3 phalanges, just like the hand. And that would be proximal, middle, and distal. I could ask questions like that in words too, to keep it simple. And then sometimes that makes it easier to do the identifications later. So the femur is the longest bone, thickest bone. Technically it's not the thickest, but it's the heaviest for sure in mass. It has a head just like the humerus. The head has a little dimple on the top, and that's called the fovea capitis. And this is an attachment site for a ligament. And it's called the ligamentum teres. It has other names too. So the ligamentum teres attaches the acetabulum to the head of the femur. So if you're upside down on a jungle gym, your leg doesn't fall off. All right, it keeps it together. So the fovea capitis is part of the head of the femur, and that is the attachment site for the ligament. It has a neck. I almost never ask about necks. The shaft is the diaphysis. Right. So here's the catch. Now here's the things you have to know. Like, remember, the humerus had the tubercles. Femur has trochanters. Greater trochanter, always lateral. It's bigger. Lesser trochanter, always medial. In the anatomical position, it helps you see right or left femur. And the femur head, of course, is medial. And there's a crest and a line, which you see between the two trochanters. And I'll show you that. That's so visual, I have to show you. So inter is between, always, and trochanter is the trochanters. So tubercle and trochanter, what's the difference? Nothing really. Nothing different besides the name and the thickness of the part, the bone marking. So the humerus has the bone markings tubercles. The femur has the bone markings trochanters. And they're both proximal. Okay, so you have an intertrochanteric line. I'll show you that. And you don't have to know these two, pectineal line or gluteal tuberosity. I won't put those on. Linea aspera I will show you, and you have to know that. That's posterior only. It's long too. It's like a ridge, really. I don't know why they call it a line. Linea aspera. It goes down the back of the femur, posterior. And it's really an insertion site for the hamstring muscles, but it's really long. It's all the way down the back of the femur. Adductor tubercle is a site of attachment, an insertion for your adductor muscles, adductor. Adduction is bringing the leg, femur, closer to the midline. Abduction is bringing it away. So you'll learn all those muscles next week. And this is important. The condyles. I'm not so concerned about epicondyles, but condyles are important. Epicondyle is just a tiny little blip of bone on top. Remember, epi means top of. And the patellar surface is anterior, right? Anterior femur. Just to get you some idea. So here it is. Again, they're always using the right side bones, which is fine because you have a good point of view. Here's the anterior view of the femur. Here's the posterior view of the femur. And that's what this is, the posterior here, anterior here. So look at the head. Of course, you could see that anterior and posterior. And this little dimple is called the fovea capitis, what that's pointing to there. And this would be the neck. Your greater trochanter is more anterior, seen anterior lateral, of course, always lateral. Where your lesser trochanter is right here. You see where that pops into the medial view. And then the shaft. The linea aspera is only posterior. And you can see the way that, it's a line there. Kind of an elevation, or I like to call it a ridge more, right? So look at the anterior distal femur compared to the posterior distal femur. So these long bulbous, large bulbous things are called condyles. The epicondyle is just a little tiny piece. So here's your medial condyle and lateral condyle. Medial condyle, lateral condyle in the anterior view. Lateral condyle and medial condyle in the posterior view. Now look at the surfaces. The patella is anterior, so you have this patellar surface. But look what you have in the back. Between the condyles, you have this fossa, and that's called intercondylar fossa. It means between the condyles. Remember, this is lateral. Greater trochanter is on that side. Medial is here. This is lateral. Greater trochanter is lateral. Lesser trochanter is medial. And this intertrochanteric line is anterior. The crest is posterior. Okay? I like to ask this one. Posterior intertrochanteric crest between the greater and lesser trochanter. Lesser trochanter is medial. Greater trochanter is lateral. The head of the femur, of course, is medial because the femur head, the head of femur, is going to articulate medially with the acetabulum of the os coxa to form the hip joint. Very important. So here's the intertrochanteric crest. This is just called the intertrochanteric line, which I'll ask you more likely crest. And linea aspera, that area of attachment of the hamstrings, only seen posterior. Intercondylar fossa, only seen posterior. Anterior would be the patellar surface, and it has hyaline cartilage, articular cartilage, because these are synovial joints. Not too much to know about the patella, right? It's got a base and an apex, and its posterior surface is articular surface because that's what's going to articulate over the femur. It doesn't connect to it. It just rides up and down, anterior and superior to inferior over the femur and tibia condyles. So you really have to know that this is the patella, number one. This is the patella. It's not a carpal. I would never put a carpal, just a picture of a carpal. This is a sesamoid bone. So posterior is important because you can see the smooth articular surface. The anterior is more like a walnut consistency. And the apex is like the bottom, like say a guitar pick, right? Pointier part. So this is inferior. And you only see it on the anterior view, right? If you're looking at a skeleton, you can't see the patella. So this is just if I took the patella and put it on a desk as a free bone. So the anterior part of the knee is called the patellar region. The posterior part of the knee is called popliteal, and I will ask you that. And I'll ask you about dorsum of foot and plantar surface of foot. Just came to mind, but we're going to do that in a couple of minutes. So the tibia is always medial, lower leg now. It has condyles too. You're going to see fibula is lateral, and they're parallel. And the fibula doesn't radiate over the tibia. It just stays where it is, even though there is an interosseous membrane that allows for very little movement. They do move, but it's very minimal, right? So the tibia is where the weight is born. We have more weight bearing. That's why it's thicker, right? It's harder to fracture, much harder to fracture a tibia. You're in trouble if you fracture a tibia. You're walking around with, or you're not walking around. You're either on crutches or a scooter. Fibula, you get a removable soft cast because it doesn't bear as much weight, and it's probably going to heal a little bit faster because of that reason. So the condyle, so the tibia has proximal parts called the medial and lateral condyles. Yeah, and I like this part. So here, I might want to start this one if it's not in your list. The intercondylar eminence of the proximal superior tibia. I'll show you that. And the fibula, of course, it has articular surfaces. Not much to talk about in the fibula. It's two parts, really, you need to know. I'll ask you about the tibial tuberosity. All right, and you should know what's anterior and posterior. It's not easy. And I will ask you the medial malleolus. That's kind of like that big bone you could feel on your medial ankle. You know, you kind of bang that once in a while. It's easier to bang the lateral one, of course. But the medial malleolus belongs to the tibia, distal tibia, down at the ankle. Distal tibia. Because the lateral malleolus is going to belong to the fibula, and it's going to be distal fibula, lateral. Fibula notch, don't worry about that. Fibula has a head. Yeah, it has a head, and that's more proximal. And there's a shaft, and the lateral malleolus. So you have to know, first of all, you have to know it's the fibula and what it looks like. Then the lateral malleolus is that lateral ankle bone that we bunk that a lot, right? It's very little tissue over that. So that's actually belongs to the fibula. Lateral, distal, towards the ankle, distally. So here's, again, same thing, the way your book shows it, which is good. This is the anterior view of the right tibia and fibula. And this is the posterior view, same thing. So let's look at the medial bone first. Remember that this is medial, the tibia. And right on top, you have these two little hills. And that's called the intercondylar eminence. Because these are going to be points of attachment for the anterior and posterior cruciate ligament, which is between the femur and the tibia. And then you have your condyles. This is lateral condyle. This is medial condyle. And this is really important. This part right here. This is the medial malleolus of the tibia. So this is medial. Again, this is the right side. Remember, this is right, and lateral. And then anterior only, you have this little bump. Again, you can't see it that great in these two-dimensional pictures. This is your tibial tuberosity. So these are all anterior visuals, right? So know the medial condyle, know the lateral condyle, know the medial malleolus, know the tibial tuberosity, and intercondylar eminence. That might not be on your list. Now the fibula, look at it. It's just a thinner bone. It's got a head, which is proximal. And here's your lateral malleolus, that thing we bang down by the ankle. It belongs to the fibula distal. Yeah, so here's the medial malleolus, which is the thicker bone, the tibia. And this is the actual bone model. Head of fibula, know it. Know it's a fibula. Lateral malleolus, know it. Now tibia, tibial tuberosity, medial condyle, lateral condyle. Remember, this medial malleolus is always medial. That's why it's called medial malleolus, if that helps you. Right? And make sure you know this is the tibia, not a different bone. It gets confusing. Now, posterior, you can see the intercondylar eminence a little bit better. You see, remember, you got to know what's medial and what's lateral. It's very difficult. You have to keep practicing this. And you have to know it's the tibia. So now this is medial malleolus. Posterior view. This is the posterior view. All this on your right of your screen is posterior view. And here's the lateral malleolus of the fibula, medial malleolus of the tibia. So the head of fibula is up here. Okay, we're not going to name the head of the tibia. We just call them the condyles, right? The medial condyle, lateral condyle. In between, intercondylar eminence, which is going to be attachment points for the anterior and posterior cruciate ligaments connecting the femur to the tibia. Very important ligament joint for the synovial joint for stability. So this is a tough one. This one you have to really, and you try to know right and left as best you can, because you really have to know the difference between the medial and lateral malleolus, and then the condyles. Remember, there's condyles on the femur too, right? There's condyles on the femur. So if you look at the femur, the condyles are distal and they're bigger, right? And if you jump back and forth like through Image Connect, you can kind of see the difference in the bones. So that, and then you know the joints. You've looked at the joints. Hopefully you won't have to review that too much, but it would be helpful. And then the lower leg. So the foot and ankle, simpler than the wrist, I think. So there's 7 tarsal bones. Why we have 7, I don't know. We probably only need 2 of those too. I'll go through each of those with you. Metatarsals, and then of course the great toe, big toe, number 1, right? Digit number 1 is the hallux, the big toe. number 1, and it counts across to 5. The book does use Roman numerals, which is cool. And the rest have the proximal, middle, and distal. This one only has distal and proximal. So here's the foot, right foot. Again, I'm not going to use this view, inferior view. I'm going to use this superior view, looking from the top. But you should know, listen to this, the top of the foot is called the dorsum of the foot. The bottom of the foot is called plantar surface. Really important for later. And you should remember plantar flexion from the joints. Plantar flexion is pointing your toes downward. Dorsiflexion is bringing your toes upward toward your shin. So the back of the foot, the part you could see, is the dorsum. The plantar is the sole of your foot, if that helps you. Okay, so let's go through the tarsals first, the ankle bones. And they're kind of makes sense. So these are all, and this one too, is all your tarsals, and there's 7. So I like you to know the calcaneus. That one I'm going to ask. That's the big one on the bottom, your heel bone. And right above that is the talus in your ankle. So talus is all this, articulated, of course, with the tibia. Right, the tibia is on top of the talus. Fibula is to the side, lateral, right? This is lateral. This is medial. Remember, the hallux is medial, the big toe, number 1, right? So on the medial side, you have a bone called the navicular. On the lateral side, you have cuboid. And then you have these cuneiforms. So these are kind of tough because medial is here, then intermediate, and then lateral, and then cuboid. So the ones I'm going to ask you, talus and calcaneus for sure. So know those. And the cuneiform start medial, intermediate, lateral, cuboid. Navicular is on the hallux side. Navicular is hallux side, medial. Right. Then you have your foot, which is metatarsals, 1 through 5. So if I point here, you're going to say that's the 4th metatarsal of the right foot. And here's the pinky toe, or the pinky side. So the pinky toe is digit number 5. And believe me, these are all long bones. They're all long bones as far as their growth. You know, endochondral ossification, they're all considered long bones. Each one of these phalanges is considered a long bone. So every one has a proximal phalange, and you have to count them. So if I point right here, I'm asking for the proximal phalange of the right, of digit number 2. You don't have to say right or left. If I point to this one, you say proximal phalange of digit number 2 of the foot. And then you have middle phalanges in number 2, 3, 4, and 5. There's not a middle phalange on number 1. So you just have distal number 1, distal phalange of digit number 1, or hallux, you could say. And then you have distal phalange, digit number 2, 3, 4, and 5. Okay?